3.
First, I will begin by auscultating all 4 quadrants of the abdomen. I'd be listening for a minute total, but for the purpose of this video, just gonna go over each area. And I would expect to hear 5 to 35 bowel sounds per minute. Next, I'm gonna be auscultating with the bell of my stethoscope, the abdominal aorta, for the absence or presence of bruits. Absence of bruits, normal finding. Next, I'm gonna be auscultating with the bell of my stethoscope for the renal arteries. For absence of bruits noted there. Next, I'm going to be percussing the abdomen in all 4 quadrants, assessing for the distribution of tympany and dullness, using my left middle finger and striking with my right middle finger. I hear dullness over the right upper quadrant where the liver is, and I hear tympany scattered throughout the quadrants with where the intestines are. Next, I'm going to be percussing for liver span, starting at the midclavicular line in the lower quadrant, right lower quadrant. I'm going to start near the umbilicus and percuss up with my middle left finger, tapping with my right hand, my right middle finger, percussing up till I hear the lower region of dullness for the liver. Once I find that area, I'm going to start from the top of below the nipple line and percuss down to the upper region of dullness for the liver. Once I get that area, I'm going to take my centimeter ruler and measure that area, and a normal finding is 6 to 12 centimeters. His is 7, which is a normal finding. Next, I'm going to be percussing the spleen on the left inferior chest wall along the costal margin, and percussing here. Laterally, I hear tympany, no signs of splenomegaly as I'm percussing here. Next, I'm going to be doing palpation. I'm going to start with light palpation and do all 4 quadrants. I'm going to be looking at the patient's face to see if they have any tenderness noted while I am palpating, so no tenderness noted. Next, I'm going to be doing deep palpation in each quadrant, and I'm going to see if the patient has any tenderness, and I didn't palpate any masses or tenderness with the deep palpation. Next, I'm going to have the patient sit up and face that way. I'm going to palpate the flank. Here, just palpating to see if there's any tenderness there. No tenderness noted on the flank. All right, you're gonna lay back, and I'm gonna palpate the liver edge by using the hook technique. Standing at the right side of the patient, I'm going to use both hands, pushing down the lower border of the liver, the lower region of dullness in the liver, and pushing in and upwards with my fingers, feeling for the liver here. And as the patient takes a deep breath in, I can feel my hand slip under the liver, palpating the edge there. Next, I'm going to be palpating the spleen, using my left hand to reach over and lift up the lower ribs. I'm palpating here for the spleen, and no splenomegaly noted. Okay, next I'm going to be assessing for rebound tenderness, and doing so, I would palpate an area of tenderness and ask if the patient feels the tenderness when I push down or when I let go. So when I push down, and if tenderness noted when I let go, that's positive for rebound tenderness. Next, I'm going to be assessing the psoas maneuver by having the patient, I'm going to have my hand on the right leg, and you're going to lift your leg up against me. Okay, and any stretching of the psoas muscle that induces abdominal pain would be concerned for inflammation of the appendix. Next, we're going to do the obturator maneuver by having the patient flex their leg at the hip and internally rotating the hip and rotating the leg out. If there's any abdominal tenderness noted, I'll be doing like a full internal rotation. If there's any abdominal pain noted with that, it'd be concern for inflammation of the appendix. Next, I'm going to be assessing the aortic span using my 2 fingers and feeling for the pulsation and moving away from there down like here and away. And once I feel that pulsation move away, I'd estimate it's less than 3 centimeters, which is a normal finding. And lastly, I'm going to have you sit up, and I'm going to do the CVA assessment by having my hand at the costovertebral area, and I'm going to take the ulnar surface of my hand and tap against that area too. Can you just turn a little bit that way? No tenderness noted. Thank you.